Good evening, everyone. So we'll be continuing our lecture on disorders of cornification. In the previous lectures, we have discussed about ichthyosiform disorders and palmoplantar keratoderma. This week, we'll be discussing a very important spotter that we usually have in our residency, which is porokeratosis. Okay, so we'll go through its pathomechanism, its clinical features, classification of sorts, and what all modalities can be used to treat it. We'll just gloss over the treatment because we know that for treating porokeratosis, essentially you need to get rid of the cornoid lamella. So we'll just go and brush towards the concepts about porokeratosis and understand it better. Okay. So without much further time, we'll just start with our video lecture this week on porokeratosis. So porokeratosis is actually a heterogeneous group of keratinizing disorder. Now, what do we mean by heterogeneous? Like all disorders of cornification, it is a group composed of different type of disorders looking same clinically. So it's a heterogeneous group of keratinization disorders. Now, all disorders in porokeratosis are characterized by an entity known as cornoid lamella. And what exactly is cornoid lamella? It's a column of parakeratotic keratinocytes. So if somebody asks you to define cornoid lamella, it's a column of parakeratotic keratinocytes in disorders which collectively form the group porokeratosis. So look at this diagrammatic representation. We know that these are parakeratotic cells because they have the nucleus in them. We know that corneocytes don't have nucleus. If they have nucleus, then that is known as parakeratosis. They have nucleus because the cell is not able to properly mature and form a corneocyte, and it's still regaining its ability to have a nucleus. So this column, this entire column is known as cornoid lamella. Okay, it is not coronoid, it is cornoid lamella. So this cornoid lamella clinically appears like a thread-like margin around the lesion. So it will look like this. Okay, and sometimes or most of the times you will see a double layered margin or two margins going together. And this is a keratotic. It's a hard, you can easily feel, you can easily palpate the edge. And that is clinically the presentation of a cornoid lamella. Cornoid lamella is more of a histological term. Clinically, it is known as thread-like margin. Okay. Now, the classification is not clear because it's a group of heterogeneous disorders. So we need to, there's essentially no issues in classifying disorders of porokeratosis into different aspects because they all behave the same. But there are major differences in between one entity as compared to another because let's say the diffuse actinic porokeratosis, there's no malignancy reported with it, or at least the chances of probability of malignancy is lower in that, while if we look at the disorder known as linear porokeratosis, the chances of malignancy is highest. So we need to identify these disorders so that we know the associated complications and problems with them. Now, another name for porokeratosis is Parakeratosis centrifugata atropicans. Why? Because it spreads centrifugally. The center may be atrophic, but remember it is parakeratosis, not porokeratosis here. Okay, or parakeratosis of Mibelli. So remember these two names have parakeratosis, not porokeratosis. Just for information, the term porokeratosis was coined because in the initial biopsies of these disorders, the cornoid lamella was found in association with sweat pores or sweat glands. So they thought that the disorder was of sweat glands, so that is why it was of pores. So porokeratosis, that's how the word was coined. But later on, it was found that cornoid lamella can occur without sweat glands also, or most likely it is without sweat glands, and that was just a chance occurrence. So, but the name stuck on as porokeratosis. Let's move forward. Now, in pathogenesis of porokeratosis, it's easiest because we don't have to remember anything. Usually, they don't ask about pathogenesis of porokeratosis, but the mutations and loss of heterozygosity or the problems of mutations in genetic regions in chromosome 12 has been implicated. Okay, other chromosome 12 is not the major chromosome that has been implicated. Other chromosomes are 15q, 16q, 18q, and this has been found in the diffuse variety of actinic porokeratosis. Another pathomechanism is the mutations in mevalonate pathway genes. Now, mevalonate pathway, what it does is, it is supposed to it is essential to form cholesterol. This pathway is important for cholesterol, and we have discussed previously in disorders or in the basics of keratinization that we require cholesterol esters to form a good lipid envelope around the corneocytes. When that envelope is not formed, keratinization is not proper and you have parakeratotic cells because the cells are not able to mature properly. You don't have lamellar bodies inside the cells, and because of absent lamellar bodies, all this keratinization problem starts. So this was the mutation in Mabillon pathway was found in multiple case studies, and now these two areas, that is the loss of heterozygosity in chromosome 12 and Mabillon pathway mutations have been implicated. And these have been implicated majorly in porokeratosis of Mibelli and also in few cases of diffuse systemic actinic porokeratosis. Now, a lot of genes in the mevalonate pathway, for example, mevalonate kinase, phosphomevalonate kinase, mevalonate diphosphate dicarboxylase, or farnesyl diphosphate synthetase, all of these genes have been implicated. You need not remember them. Just remember two issues: genetic mutations in mevalonate pathway and loss of heterozygosity in chromosome 12. These two have been implicated. We have already discussed that mevalonate pathway is responsible for keratinocyte growth and differentiation, cytoskeleton assembly, and intracellular signaling. So it is just a pathway required for proper functioning of corneocyte. Proper corneocyte formation. If that is not working properly, you don't have proper corneocytes leading to cornoid lamella. Another gene, which is the SLC17A9, have been implicated. It is a gene for vesicular nucleotide transporter, but that is just I mentioned because it's mentioned in Rooks. Otherwise, we need not remember anything. Just remember two things: chromosome 12 and mevalonate pathway gene mutation. Let's move forward. Now we know it's a centrifugal process. Centrifugal means it grows from inside to outside. Okay, outside. So that's a centrifugal process. That is how the lesion migrates. Initially, it's smaller and then gradually it becomes bigger. So it spreads, okay, and it reflects the migration of clone of abnormal cells. Now, what do we mean by that? So when we're discussing biopsy, it will be clearer to you. But let's say if this is the epidermis, okay, so this is dermis and this is epidermis. And in this, you have an oblique clone of parakeratotic cell. And this is your cornoid lamella. So as the cells grow, they spread in the periphery, and that is the reason why porokeratosis has a centrifugal spread. Okay, mutations in P53 and retinoblastoma gene, which are tumor suppressor genes, they are found to be overexpressed in cornoid lamella in multiple studies. Reduced immunity have also shown to be a reason of porokeratosis. There is an entity known as porokeratosis in immunosuppressed individuals. So, what theory is proposed is that the immune cells, they are constantly on a lookout for corneocytes which are not behaving properly and remove them from the system. If they are not able to do that, you have abnormal corneocytes leading to porokeratosis. That theory has been implicated in porokeratosis in an immunosuppressed patient. Okay, we'll discuss that entity later. Second hit somatic mutations have been implicated in linear porokeratosis that presents in a Blaschkoid pattern. Now, porokeratosis are associated with malignancy. At least some kinds have a stronger association as compared to other kinds. Roughly about 7 to 11% of the cases can have skin malignancies, and the most common tumor that has been reported is squamous cell carcinoma. Other carcinomas like BCC, Bowen's disease, has been implicated in porokeratosis. Now, all variants have a reported an association with malignancy except the punctate variant, and this could be a good MCQ question. Okay, except the punctate variant. Let's move forward. So, I've already told you that it is difficult to classify porokeratosis. So, what the Rooks has done is classify on the basis of clinical picture, okay, clinical distribution, clinical appearance, and also the associated complications. So first you have disseminated superficial actinic porokeratosis, and subset of that is disseminated superficial porokeratosis of immunosuppression, disseminated superficial porokeratosis of childhood, porokeratosis of Mibelli, giant porokeratosis, Palmoplantar porokeratosis of Mantoux, linear porokeratosis, and Porokeratosis Ptychotropica. Now, all the variants that I have implicated in bold are the variants that you should know about at level residency, and we'll discuss them further in the lecture. We'll start our discussion first with DSAP, or Disseminated Superficial Actinic Porokeratosis. It's an autosomal dominant disorder, and it's the most common type of porokeratosis. Occurs in middle age with male to female ratio 1:2. That means females are twice as affected by DSAP as compared to males. Clear? Clinically, it consists of multiple small annular, asymptomatic or mildly pruritic papules, roughly about 2 to 5 millimeter in size, symmetrically distributed over the extremities majorly. Okay, so we'll have this kind of varying size, annular, small, multiple asymptomatic papules with a keratotic margin. So this is a keratotic margin. The papules are surrounded by a keratotic ridge. Ridge means that if you look at sideways, this is the normal skin, this is the keratotic ridge, and then this is the center, which may be atrophic. So this is center and this is the ridge, the raised part. And this raised part, if you take a biopsy from the margin, always you have to take a biopsy from the margin if you're biopsying a porokeratosis. This ridge is the place where you have the oblique column of parakeratotic cells known as the coronoid lamella. Clear? So let's move forward. Majorly, it occurs on sun-exposed areas. That is why the name actinic is there. That means sun-exposed areas. It can have later a generalized distribution, but it spares palm, soles, and mucosa. These areas are spared. So since it is on sun-exposed areas, therapy like photochemotherapy or radiotherapy, where you have delivery of excess radiation to the skin, can be the sites where this DSAP can appear. Now, the association with malignancy is not that profound. There are only few isolated cases. It's the variant with the least probability of associated malignancy. Let's move, and this is actually a very important point. Okay, so let's move forward. Now here we are seeing disseminated superficial actinic porokeratosis. This picture I've taken from Rooks. And you can see this keratotic margin here. You can see this. You can actually appreciate it to be raised, and more so here. So this kind of annular circular keratotic margin is what is the presentation of porokeratosis. Now the center can be atrophic, it can be normal, it can be scaly. So center can have different morphologies, but the diagnostic, the clinical sign is the raised keratotic ridge in DSAP. And it is multiple. The next picture will show you multiple DSAP. So here you can easily appreciate, this is taken from Dermatopathology McKay's book, page 200. So here you can see multiple porokeratosis. One is here, one is here, and multiple porokeratosis. So if you see multiple lesions of porokeratosis on sun-exposed areas, think of DSAP. And this is a larger picture to show you importantly than what this is the keratotic rim. Okay, so you need to have a keratotic rim to label it as porokeratosis. Let's move forward. So here you can very well appreciate multiplicity of the lesions. You can see so many porokeratosis in what I think is the forearm. Okay, so many porokeratotic lesions are there. I'll just remove the markings so that you can better appreciate these kind of multiple plaques. And the black arrows will show you individual porokeratosis. Okay, individual hair, or you have it one hair. So these all are individual lesions. Let's move forward. Now, the second entity is disseminated superficial porokeratosis of immunosuppression. So remember this word, immunosuppression. Now, porokeratosis have been implicated or found after disorders like renal, hepatic, cardiac transplantation, bone marrow therapy, electron beam therapy, chemoradiation, biological usage, or steroid treatment with hematopoietic malignancies. HIV infection, type 2 diabetes mellitus, these all have been isolated incidences with porokeratosis happening after the disease has been set. The clinical features are same as DSAP, and here the history of sun exposure is less likely because it is happening because of immunosuppression. Okay,
So here, immunosuppression is the entity which plays an important role. The sun exposure is not that implicated in the etiology of disseminated superficial porokeratosis of immunosuppression. Okay, so let's move forward. The third subset is disseminated superficial porokeratosis of childhood, or DSPC. Again, autosomal dominant. Remember, all disorders are autosomal dominant except CDAGs. Some sporadic cases have also been found. In this disorder, you have widely disseminated flat lesion, usually in childhood, roughly about 5 to 10 years of age. So all the previous disorders, they were in middle age, third to fourth decade, second to third decade, over sun exposed areas. But this one occurs earlier in childhood, 5 to 10 years. Now, this kind of lesions, if they also involve palmoplantar areas. So DSPC also involves palms and soles. Palms and soles. Similar to another disorder known as Porokeratosis palmaris et plantaris disseminata. So we'll discuss this disorder further in the lecture, but these two porokeratotic forms do involve palms and soles. Now coming to the fourth entity, Porokeratosis of Mibelli, and that's an important porokeratotic disorder after DSAP. So autosomal dominant. If it is autosomal dominant, you have an earlier onset of disease. But there are sporadic cases in that you have a late onset. So it can occur mostly in infancy or childhood. But here, males have twice the probability of developing porokeratosis. Remember DSAP. In DSAP, females were twice as implicated in porokeratosis. Here, the ratio is reversed. Males are twice more common. So remember this ratio for M for Mibelli, M for males. Okay. It consists of asymptomatic single or scanty larger lesion, mostly over the limbs, so similar to DSAP. And they have a raised more than 1 millimeter fine keratotic elevated border with a central groove. So if it has a central groove, it will have a double edge. So if in fact you look at this diagrammatic or schematic representation, and you can see that the margin is made up of two layers. So you can easily, sometimes if you look closely, you can easily appreciate the two layers in the margin. Okay. But one thing to remember is that the keratotic rim is thicker as compared to what we see in DSAP. Okay. Center is usually atrophic, but maybe hyperkeratotic, hyperpigmented, hypopigmented, anhydrotic. All of these kind of secondary morphologies can be seen in the center. Other areas involved are face, scalp, nails, genitalia, oral mucosa, and cornea. Let's move forward. So this picture I've taken from Rooks, and in this picture you can easily appreciate the thick keratotic rim. Okay, you can see the thick keratotic rim. It is very much thicker, a lot thicker than what we have discussed previously in DSAP. Okay, and see that the central area, the area enclosed by the keratotic rim is atrophic, significantly atrophic. Now it can be hyperkeratotic or hypopigmented or hyperpigmented, but the most common presentation is the atrophic area inside the porokeratotic rim. Okay, so let's move forward. So most of the time you see porokeratosis like this, you may confuse it with DLE or SCLE kind of lesions. But porokeratotic has a good uh, two-layered keratotic margin surrounding it. Let's move forward. Now, the fifth entity is giant porokeratosis. It's an extremely rare entity. Most commonly, it occurs on the foot. It's called giant because roughly the size is about 20 centimeter in diameter with a surrounding elevated edge of 1 centimeter. Okay, so the elevated edge, the keratotic rim that we were talking about, is about a centimeter thick. Okay, it's a centimeter thick, and this whole dimension is about 20 centimeter or more. Okay, so when it reaches that size, it is known as giant porokeratosis. Clear? Larger the size, greater the chances of malignant transformation. That means that giant porokeratosis is the first porokeratosis that we are hearing about, which has a good association with carcinomas. So larger the size of porokeratosis, the larger the probability of developing
malignancies. The sixth entity is Palmoplantar Porokeratosis of Mantoux. Okay, autosomal dominant. Males are twice as common presentation in as compared to females. So M for Mantoux, M for males. It starts earlier as compared to other forms in adolescence or early childhood. Now here the plaques are bilaterally symmetrical, small, relatively uniform in size over palms and soles more than the body and mucosa. That means other areas can be involved, but palms and soles are the major area of involvement. That is what is known as palmoplantar porokeratosis. In some punctate PPK, so remember in the part 1 of palmoplantar keratosis or non-syndromic palmoplantar keratoderma, we have discussed punctate PPK. So punctate PPK over palms and soles are a good differential of palmoplantar porokeratosis, and you can in fact see cornoid lamella in the biopsy. So that it could be a very confusing disorder to distinguish between these two. But these PPK will not have marginate lesions, so they are known as false porokeratosis. Clear? Annular lesions may occur. The other names are Porokeratosis palmaris plantaris disseminata or Porokeratosis punctata palmaris plantaris. Okay, just for academic sake. Points to remember is autosomal dominant palms and soles can be confused with punctate PPK, starts in adolescent or childhood. So just remember these 4 points. So this picture I've taken from Fitzpatrick, and you can see this involvement of palmar skin with a thick keratotic rim. Why thick? Because the skin itself of palms are very thick, so the perikeratotic column is also thick. Okay, so that is why in psoriasis or in other papilloscopic disorders like lichen planus or even in fact for atopic dermatitis, lesions on palms and soles are thicker as compared to the rest part of the body because the inherent skin is thicker. Let's move forward. So these are the ridges when we were talking about the keratotic ridge. Now the seventh variant is linear porokeratosis. Okay, starts in childhood and follows Blaschko lines. So remember, Blaschko lines are the imaginary lines that trace the migration of different cells that form the different skin layers. Okay, so one part from the neural crest is forming a certain segment of the skin, and that different segments together form Blaschko lines. So when Blaschko lines are involved, you have mosaic manifestation. That means if this is, let's say, the arm, so what you will see is kind of a mosaic presentation. That means only a segment would be involved, not the entire area, not discretely single lesion, but a segment, a contiguous segment would be involved. Okay, so it is unilateral over extremities, uh, more common than generalized, a lot more common. So most of the time it will be unilateral, but it can in rarer instances have a generalized presentation. So what happens is that you have an abnormal clone of epidermal precursors. That means cells that during embryonic development, which will eventually form a skin of a certain part, those cells have problems or those cells have mutations in them, and those cells have the propensity, the probability to develop into porokeratosis. And when these cells migrate and form a segment of the body, that entire segment becomes porokeratotic, and that is what is known as linear porokeratosis or a line-like porokeratosis. Malignant degeneration and metastasis have been reported in linear porokeratosis. It has the highest predilection of malignancy of all porokeratosis. So as compared to all other porokeratotic disorders, linear porokeratosis has the highest propensity to undergo malignant transformation, and this makes it a very important point to consider. Okay, very important point that can be asked in vivas or exams. Now remember, DSAP can also appear linearly, but you will not have that kind of contiguous nature. Let's move forward. So here you can see a papilloscomus disorder with a good keratotic ridge. Let me see if I can mark it for you. So this I've taken from Fitzpatrick, page 903, and you can see this scaly keratotic margin around the lesion, and it is appearing linearly. So this whole area, it is affecting the area in a line. Okay, so in a band, and that is the presentation of linear porokeratosis. Clear? Let's move forward. So this is another picture of linear porokeratosis which I've taken from Andrews. So A is Andrews textbook of dermatology, 13th edition, page 572. And you can easily look at the linear arrangement of the porokeratotic rim, and this area is an SCC which has developed. The squamous cell carcinoma arising over linear porokeratosis. Why? Because linear porokeratosis has the highest probability of transforming into a carcinoma. Let's move forward. Now, the eighth variant is Porokeratosis Ptychotropica. It's a rare disorder, occurs as wide as 6 to 84 years, mostly involving the males, and the word comes from tyche, which means fold in Greek. Okay, so Ptychotropica, tycho means fold, and tropica means movement. So porokeratosis that moves in towards the fold or inside the fold. So it has brownish or reddish macules, symmetrically involving most commonly over the perianal region around in the gluteal cleft, and it is highly pruritic. So this is an important point. Most of the porokeratotic lesions initially were asymptomatic or only mildly pruritic, but porokeratosis ptychotropica is highly pruritic. Multiple corneal lamellae can be seen on biopsy, and linear porokeratosis or DSAP may coexist. Now remember, in a single individual who has one type of porokeratosis, another type of porokeratosis can also be there. So multiple times can coexist in a single patient. So few points that you have to remember about Ptychotropica is that it occurs on folds, most commonly over the perineal region. It is highly pruritic, and multiple coronoid lamellae can be seen on biopsy. Multiple coronoid lamellae. Let's move forward. Now this picture I've taken from Bologna, which shows you different type of porokeratosis together. Okay, so the first one is porokeratosis of Mibelli, so an isolated plaque over the extremities, porokeratosis of Mibelli. Okay, another is actinic porokeratosis in renal transplant patients, so it is often immunosuppression variant. The third one is also actinic porokeratosis in immunocompromised patient. Notice that the center is atrophic. Fourth one is DSAP. You can actually see that they are multiple, like we see in DSAP. The fifth one is the solar facial variant. So this kind of multiple porokeratosis that you're seeing on the face, on the sun exposed area. So solar facial variant is also implicated. The F image shows you a dermoscopy. We'll be discussing dermoscopy the next slide, don't worry. This image shows linear porokeratosis developing linearly, while H shows punctate porokeratosis. So over the soles, you can see this kind of small puncture marks. And this is Ptychotropica. So you can see the special involvement of the intergluteal area, the gluteal cleft, or the perianal region with reddish brownish plaques. So this is the Porokeratosis Ptychotropica. That means going inside the fold. So you can open up Bologna 5th edition, page 1921, and you can see this image clearly. Let's move forward. Now this is porokeratosis on dermoscopy, and on lesion you can easily appreciate the keratotic rim. Let me change the color. So you can easily see the keratotic rim. Okay. So you other features that have been described in dermoscopy of porokeratosis, it is brown colored dots, globules in the center area. So can you just appreciate these dots which are occurring together here, all this area which appears a bit purplish, a bit violaceous. These are nothing but thickened epidermal areas, and these are brown colored dots and globules in the center areas. You have irregular double marginated white track border. So the scaly rim looks more of a white track border under illumination. A focal brownish discoloration here. So here you can see the brownish discoloration. A little bit of here you can see a focal brownish discoloration. These are the features of porokeratosis in a dermoscopic examination. Now, histopathology, and that is very important because that is what is usually asked, the biopsy findings of porokeratosis.
So in biopsy, you will see a poorly staining parakeratotic stratum corneum cells. You will see a column of parakeratotic cells, which is the cornoid lamella, running obliquely through normal cells. Okay. So again, let's say this is the epidermis and this is the dermis. You will see an obliquely running parakeratotic column, and this is cornoid lamella. Clear? The underlying keratinocytes, that means just at this level, the underlying keratinocytes will be large, vacuolated, dyskeratotic, and pleomorphic. That means they will have multiple forms, multiple shapes. They're not able to form keratin properly, large with vacuoles inside them. The stratum corneum will be hyperkeratotic. Remember that just below the cornoid lamella, just at this level, the granular layer will be absent. Why? Because the cells are not properly functioning as corneocytes, so they will not be able to form granules, they will not be able to form the granular layer. So just below the cornoid lamella, you will have absence of granular layer, and this is an important biopsy finding. If somebody asks you about histopathology of porokeratosis, you need to mention this also along with cornoid lamella. Let's move forward. Underlying lichenoid tissue reaction may be present. So initially it was found to involve the sweat pores. That's where the word porokeratosis comes. The center shows features of atrophy. Occasionally hyperkeratosis can be seen. The papillary dermis shows fibrosis with few melanophages. Okay, let's move forward. So look at this slide picture from Dermatopathology Mackey's page 200, and let's take few seconds to identify whether you can find that porokeratotic column. Now remember how to find that. As I said, it's a poorly staining area. So look at this area, obliquely running through the corneal layer. This is the coronoid lamella. Clear? I'll remove the marking so that you can better appreciate. So you can see the obliquely running parakeratotic column with corneocytes in which you can see little dots. Those are nucleus. And one thing that you can appreciate is that the granular layer is from here to here, from here to here, but it is absent just below the cornoid lamella. Okay, so just below the cornoid lamella, you will have absence of granular layer. Clear? You can see the cells containing granules, especially if you look at these areas, but just below the cornoid lamella, you don't have a granular layer. Let's move forward. So this is the cornoid lamella. Let's look at this lesion in this area of the slide a bit magnified. So the granular layer somewhat ends here, and you don't see cells filled with granules here. What you see here are keratinocytes which have vacuoles in them or empty spaces in between. You can have dyskeratotic cells also. So dyskeratotic cells, vacuoles just below the cornoid lamella. Clear? And you can in fact appreciate this obliquely running cornoid lamella on top. Okay. So below the cornoid lamella, you will have absence of granular layer and you have dyskeratotic keratinocytes with vacuoles. Okay, let's move forward. So this is another picture from Dermatopathology Mackey, and you can very easily appreciate the obliquely running cornoid lamella. Okay, and if you again look closely, you will find that the granular layer is running from here to here, and it is absent, and then it starts running from here to here. So it is not present just below the cornoid lamella. That's what I wanted to show. A very clear picture of cornoid lamella. Additionally, you can have a lichenoid tissue reaction, not a lichenoid tissue reaction per se, but you have perivascular lichenoid infiltrate just in the upper dermis. So this is a vessel, this here is a vessel, and here you have the lymphocytes. So you have lichenoid or lymphocytic infiltrate around the vessels. Let's move forward. So this again shows cornoid lamella, and one thing to appreciate is look at this area.
Look at this area now. This is just below the corneal lamella, and you will see large, poorly staining keratinocytes with full of holes in them. So that is the dyskeratotic keratinocytes, which have a lot of vacuoles. The keratinocytes at the base of corneal lamella are not proper. Okay, this is what I wanted to show with this. I'll remove this and so that you can easily see. Okay, let's move forward. We can see that the granular layer is absent. You can easily appreciate granular layer here, a little bit here, but mostly over the initial part, but it is not at all present just at the base of corneal lamella. Management is easiest. It's the easiest thing about porokeratosis after pathomechanism. Just remember one thing which I'm going to tell you right now. This is the epidermis. This is the dermis. Clear? This is the obliquely running parakeratotic column or the cornoid lamella. As long as this column remains, porokeratosis can come back. So whatever you're going to do, you have to destroy this cornoid lamella. So this cornoid lamella has to go. It has to destroy. So whenever you're doing any kind of surgical modality in a patient of porokeratosis, tell them that the area will be scarred. Okay, if it scars, that means you have gone deep enough to remove the entire cornoid lamella. If you get this cornoid lamella out, then you will say that you have treated porokeratosis. It can still come back, but very low chances. But if you leave those cornoid lamella or cells containing in this cornoid lamella in situ, porokeratosis will come back. So essentially, you have to remember that you have to remove the cornoid lamella. Okay. Now the treatment can be conservative and just observation would do. If it's a small plaque in a hidden area of the body, you may just observe it if required. Photoprotection is advised because if you have one porokeratosis, you can have other porokeratosis also. So protection from sun is advised. The major modalities to treat porokeratosis right now is surgical. So you do deep dermabrasion to remove the cornoid lamella, removal and then grafting the area with skin grafting, especially when the center is atrophic, or you can use radiofrequency ablation to get rid of this cornoid lamella. Clear? Topical modalities like the calcitol, tacrolimus, retinoids, 5-FU, imiquimod cream, bleomycin have been tried, which have shown only some benefit, not proper benefit, and porokeratosis tends to reoccur when the treatment is stopped. Why? Because the entire cornoid lamella is not removed. Other modalities like cryotherapy, CO2 laser, PDL, photodynamic treatment have shown variable results. Now, a future or a new modality or a new form of treatment is applying topical cholesterol with lovastatin. So what lovastatin does it blocks the synthesis of cholesterol inside the body. It's a statin. We know that in porokeratosis, problems may rise in mevalonate kinase pathway. Clear? So with lovastatin, you block the pathway, but if you have blocked the pathway, none of the cholesterol will be formed. So you supply cholesterol from outside by applying topical cholesterol, so that the cells can have access to normal cholesterol, not the abnormal cholesterol it was forming in porokeratosis. So this is a future treatment where it has shown variable results, but this is one area which you can have non-surgical improvement in porokeratosis. Clear? But remember, as of now, the best treatment is through surgery. I've used radiofrequency ablation to get rid of those keratotic rim, and I've not seen a recurrence till now. But remember, it is best to leave a scar so that you know that you have gone deep enough. So with that, we'll finish this week's lecture on porokeratosis. These are some reading recommendations, but if you've gone through this lecture, you will not need it, that I'm sure of. Again, shameless plug, I'll just advise that we have crossed more than 100 members and we have crossed that within a month. So that is, in my opinion, a very remarkable feat, and I thank all the premier first 100 members of the channel. Thank you very much of showing your trust in me that whatever I am supplying week after week after week, it is of some benefit to you. That is why you have chosen to become a member of the channel and support me more than what I have actually asked for. Now, other people who have not yet joined, do consider becoming a member. It helps me, it motivates me to keep making these videos week after week, and different, you could say, different, not powers per se, but a certain kind of you will get certain benefits in becoming a member. You will have an extended video with extra information, with colored clinical pictures, with extra in-depth explanation, and all the other modalities like dermoscopy or viva questions. We are working on it. I'll make sure I make newer videos. And what are new videos we have to take into consideration? I ask my members first. So right now the membership is just available on a discounted rate of 59 a month till the end of this month, till the end of this year. From next year, the prices will change. So till now, make use of it. If you have not become a member, do it now. Pay for 59, or you can just pay on 30th December. Okay. So let's move forward. So thank you for being with me and listening to this video. And we have finished porokeratosis. It's an important spotter. It's an important disorder of cornification. It is very easy to recognize. It is so pathognomic on clinical examination that sometimes you don't even require a biopsy and you go ahead with surgical ablation. Okay. So I will not take much time. I'll just say my goodbyes to you, and we will meet next week with a newer topic. Till then, adios and bye bye.